online. So there'll be a web link that will be available where you could go to view the presentations in part or in total at some point on the internet in the future. And our projectionist extraordinaire, Caleb, who's been helping us, is going to be working on that. He thinks that it will be available within a week or so. So what we need to do is then be able to disseminate the link. And I think that will be probably posted on our website, or we'll make it available through the people who you registered with for the conference, that you can call and get some information about where the information will be online if you wanted to re-refer to it again. Okay. So I'm going to just pick some questions and then direct them at individual panel members. But you may find that other people will chime in here as well. And hopefully it'll be informative. So I'm going to ask Dr. Maldreyer to comment. There were several questions that asked about your comments related to rehabilitation for multiple sclerosis and the benefits of therapy and exercise. And can you expand a little bit more on that? I think you used the term use it or lose it. And what does that mean for patients? So let's get this turned.
You all know
I want to get the microphone turned on for you. Press and hold. Other thing we do is pass this. I don't think it's on.
Yeah. Could you hear me okay? No.
Yeah, use that. So we'll pass this one back and forth. Just hold it up to your mouth. And
Okay. So what I mean is when you have flare-up or progression, the only way to retrain nerve or have a different bypass, alternative pathways, is to exercise. So there has been a lot of research done on rehabilitation, and more and more tools going to be developed to help us really define what part of the brain can be activated by different type of exercise. So for example, functional MRI or other MRI imaging modality have shown that when you going through strenuous exercise, OT and PT, a different part of the brain get stimulated and activated, so you can actually rebuild alternative pathways to compensate what's been lost. So we need more studies to demonstrate that effect. But you all have the experience why you're not exercise. As I'm losing a lot. Just compared to my son, he's playing soccer. He can run a lot faster than me. So it's a common sense, even though without scientific proof. So I think that's common practice. We encourage people to go through rehabilitation. Yeah. Okay.
So we had a lot of questions about stem cell-based therapies for multiple sclerosis, and I don't think you heard any of us say the two words stem cell together this morning. Maybe I'll ask Dr. Siegel to just comment briefly on what is the state of the art, so to speak, about stem cells in MS, and where do you see this field going in the next few years?
Well, there's a lot of exciting research on stem cells in multiple sclerosis. It's not quite ready for prime time. There are a lot of issues with stem cells. Just to briefly describe what stem cells are, they're very immature cells that have the potential to develop into different cell types. And the ultimate goal, I think, when many of you think about stem cells, you think about cells that could form into new nerve cells or new cells that could regrow the myelin sheath. That type of stem cell is being studied in animal models, but there are no clinical trials right now of that type of stem cell in multiple sclerosis. There is a small study going on in another neurologic disease, ALS. It's very preliminary. There are some concerns with stem cells in that because they're immature and they divide quickly, they have the potential to form into tumors. Also, there's really no way to control at this point where they migrate to. So if you inject one of these immature cells, we would hope they'd go to an MS lesion and initiate repair, but not enough is known about how to control that. There's a different type of stem cell that is not within the category that I just mentioned. These are stem cells that are in the bone marrow. Most of the stem cells in the bone marrow will form into white blood cells and red blood cells that enter the bloodstream. But there is also what's called a mesenchymal stem cell, which is an immature stem cell that may have more potential to grow into a nerve-like cell. Those cells have been shown to be useful in the animal model of multiple sclerosis to have some therapeutic value. But surprisingly, they don't seem to develop into new nerve cells or new myelin-forming cells. They actually seem to have an anti-inflammatory effect that's beneficial in MS. That was completely unexpected. But based on those animal studies, there are now two small trials with just a handful of patients going on in Israel and one in the States. Once again, these are single-center trials with just a handful of patients, and they're harvesting the bone marrow from the participants and growing out these mesenchymal stem cells. So that's an exciting new avenue, and we'll see what happens with that. In terms of the more traditional stem cells that you may be thinking about, there's a tremendous amount of research going on, not quite ready for prime time or clinical trials in MS at this point.
Great, thank you. So there are a lot of questions related to new and emerging therapies for multiple sclerosis. So I'll pick a couple and direct these at Dr. Braley since she spearheaded that conversation. So one of our audience members asked about the criteria for ocrelizumab in primary progressive MS. A lot of questions about how can we treat progressive MS. And so what can you tell us about which patients might be eligible to participate in that study, if that's known?
Actually, well, obviously we have a lot more of the details about the relapsing study because that's the one that we're involved in. If I could refer you to a couple of places, one would be clinicaltrials.gov, which might give you more information about which sites across the country are actually doing the primary progressive MS study, if the study is still enrolling, also how long that enrollment period is. I can also try to find more information if you're interested on that, but because we are involved in the relapsing study, I have to say I don't have a lot of the criteria right now for the primary progressive patients. So I just wanted to make patients aware that that is ongoing, and this may be a drug that could be used for primary progressive MS as well.
And sorry, Dr. Siegel has a comment.
So there was a trial of rituximab, which is the drug closely related to ocrelizumab in primary progressive multiple sclerosis. And overall, it did not work, wasn't found to work. But in that study, they were doing frequent MRIs on patients. And even though we think of progressive MS as not involving as much inflammation in the brain and spinal cord as relapsing disease, there are some patients who still have ongoing inflammation. It may be less frequent, but it's still part of the disease process. And the only way right now that you could identify those patients is by doing very frequent high-quality MRI scans to capture the inflammatory events when they occur. Well, in the study of rituximab in primary progressive MS, when they reanalyzed the data, there was the subset of patients that had some evidence of inflammation did benefit from the drug. So we're actually proposing a large study through the VA system to follow patients with progressive MS, taking them off beta interferons or Copaxone if they're currently being treated with those, and seeing how many of them have new inflammation. If they develop new inflammation, they're put back on drugs, but that may help us identify a subset that could benefit from drugs like ocrelizumab. And it's based on these early studies and based on our own studies where we followed progressive patients with frequent MRI scanning, it may be up to 30-some-odd% of patients with progressive MS that fall into that category who aren't being treated aggressively right now because we don't know that they do have an inflammatory component to their disease.
So there were There were also a lot of questions about the subject that I covered, diet and dietary supplements in multiple sclerosis. Again, we won't be able to get to them all. One person asked about, is it preferred that you take vitamin D2 or vitamin D3 as a supplement if you're going to take vitamin D? And the answer to that is I'm not aware of any difference that one is preferred over the other. There really aren't great studies to suggest that one is more effective at supplementing vitamin D stores in the body. So as far as I can advise you and tell you, you're equally off taking one versus the other. There was another question about foods to avoid in multiple sclerosis. So I talked about things that you can take, but are there things that you shouldn't be taking or ingesting that might be detrimental to your multiple sclerosis? Again, I think it's easy for me to say you should eat a healthy diet, and as Americans, we together don't eat a very healthy diet, and so there are definitely overall global health benefits from watching your diet, eating a balanced diet, watching the intake of high saturated fats and cholesterol-containing food. But I am not aware, correct me if I'm wrong, anybody, that there is any one specific thing that ought to be avoided in your diet just because you've been diagnosed with multiple sclerosis. Okay, good.
French fries from McDonald's.
So again, to Dr. Braley, two questions on the same card, both up your alley.
Okay.
So one has to do with the interactions between multiple sclerosis and anesthesia. So do patients with MS react differently to anesthesia during surgery than people who don't have MS?
Yeah, that's a good question. I guess it depends on what kind of anesthesia you're talking about. We don't think right now that there's a connection between worsening of MS and general anesthesia. But there have been a few case studies done over the years showing that patients who have local anesthesia, where they go in right to the nerve in the back and they inject it or numb it up, that those patients may take a little bit longer to recover. But I don't think there's really enough hard evidence either way to say that that's really the case. And in terms of just along those same lines of surgery, we want to make sure, well, the study we would like to do and what we're getting ready to do is looking at whether or not patients' relapses or just their disability worsens after the anesthesia or the surgery itself. We currently don't think so. We think when patients get worse after surgery, it's usually because they have some sort of a complication like an infection or something along those lines, or that they get deconditioned from just being in bed for so long. But we really need to do some stronger studies to prove that. There really isn't a lot to go on, and that's why we want to do the study.
Okay, and also to Dr. Braley, there were several questions about sleep disorders in multiple sclerosis, and we hear you're an expert at that. So one questioner asks, are sleep disorders common in MS patients? I only slept a half hour last night, and that happens a lot.
I know who asked that question. Yes, so sleep disorders are very common in multiple sclerosis. There's several different sleep disorders that are common. One of them is definitely insomnia. So there's a number of things that can cause insomnia, but MS patients have a lot of the risk factors for insomnia. They have a lot of things that can keep them awake. So pain at night, spasms, bladder issues, these are all things that can contribute. Anxiety, just in general, just not being able to turn off your mind. And we do think that insomnia is more common in MS than in the general population. Restless leg syndrome is another really important one. We think because of the nervous system and the way it's injured in MS, that patients are about 3 to 5 times more common to have restless leg syndrome than patients in the general population. And restless leg syndrome, I'm not sure if many of you know what that is, but that's this urge to constantly want to move your legs. It usually happens when you're sitting quietly or when you're trying to go to bed. And then we also think that it's possible that sleep apnea, which is a condition where you end up holding your breath at night and you aren't able to fully open the airway and breathe, might be more common in multiple sclerosis, but we're still studying that. So yes, long answer.
Okay, so I'm going to open this one up to the whole panel, not directed at anyone in particular. So somebody asks, Is there a point that a doctor should give up treating a patient with MS because they believe they are too far progressed in their disease?
Well, I could start first. Well, as I talked about progressive MS, there's a lot of symptomatic treatment that we could offer to patient, even though there's no particular disease-altering drug at this time. But there's symptom we can control and help be more comfortable. Is walking speed, as I mentioned, a new drug, interferon, and muscle relaxant to help relax the muscle. Okay, so medication for mood, fatigue, bladder and bowel. There's a lot of other issues come with the disease. So there's never a time we'll say it's, to give up on a patient. That's, and plus there's hope. In the next decade or so, there's going to be treatment for progressive MS. It's being currently pursued. Okay.
Yeah, I mean, our stance is never to give up on a patient. That goes against everything we believe in. There may be a time in which withdrawing certain medications is appropriate because they're no longer likely to be helpful and may be causing side effects. But we always want to follow our patients and do whatever we can to help them deal with the disease. And as Dr. Maldreyer said, that's with symptomatic medications, physical therapy, et cetera, but also to provide support, social support. And we are constantly trying to think of new ways to help our patients. Sometimes we try intermittent intravenous steroids, and that helps some patients with progressive MS. In patients who are declining at a quicker rate, many times I personally will try chemotherapy. We are now talking to doctors from different specialties who use certain procedures to dampen inflammation, and we're going to see if we could do a study of those procedures in progressive MS. One of the missions of the MS Center, one of the main goals is to come up with better ways of dealing with progressive disease and to understand it better. So we never would give up on a patient.
Yeah, I'd reiterate what Dr. Siegel said. I would not equate treatment with prescribing medication. So it's absolutely true that there are some times where certain medications that you're on are no longer helping and they may be causing more harm than good, so discontinuing the treatment might be advisable. But that doesn't mean we stop treating the patient. So we need to look at symptoms, their psychosocial situations, emotional needs, et cetera. I think it's just incomprehensible that we would talk about stopping to treat our patients. I'm going to turn the question back to Dr. Siegel one more time because there's an interesting one here. I think you have heard a little bit about this. Is there any truth to the idea that irradiating blood might be a treatment for multiple sclerosis? And what can you tell us about that?
I wonder who asked that question. Very interesting. So we are beginning to explore that, actually. There is a treatment called extracorporeal photopheresis, or ECP for short. And this is used actually by doctors who treat patients who've undergone bone marrow transplantation for cancers. One of the complications of bone marrow transplantation is that new white blood cells that are injected into patients after they receive chemotherapy begin attacking tissues in the host, the person who receives those cells. So in a way, it's kind of similar to an autoimmune disease where an overactive immune system begins attacking the body. They have found that if you remove some white blood cells from patients, expose them to UV light, they add a chemical called a photosensitizer, and then they re-inject those cells, it has some effect in dampening the immune system, and those patients do a lot better. So we have started to treat a handful of patients in that way, trying to get insurance coverage. Most insurances won't cover it. And we've had some anecdotal promising results, and we're in the process of proposing a trial with our colleagues in the bone marrow transplant unit to do this in a rigorous, controlled way on a bigger scale. So right now, I mean, it's an experimental question, but it's something that we're exploring.
Okay, so maybe I'll direct this question at Dr. Braley. So if my MS is stable, do I need to see my doctor more than once a year? What are the benefits of more frequent appointments?
That's a very good question. I think it is just a good idea to make sure that, for one thing, that you really are stable, from visit to visit. It's helpful to have an exam just to confirm that, and to also make sure that your MRIs are stable. That's one reason. But even if things are truly stable, it's good to come in once in a while just to find out about new treatments and new things that might be available for you. I think it's always beneficial to come and just touch base with your MS specialist once in a while, and we do encourage that. So it might not mean that we have to change your treatment at all, but at least it'll give us a sense of where you are from year to year, and also give you a sense of what's going on in the treatment world.
Yeah, I guess to just elaborate on that a little further, many times in patients with relapsing or remitting MS, the symptoms themselves are often just the tip of the iceberg. There's a lot of disease activity that's happening, quote unquote, below the surface. And what I mean by that is we can see changes on the MRI scans, new lesions showing up, old lesions going away, even in the absence of new symptoms. So there are situations where the MRI scan can show progression or accumulation of new spots that aren't associated with new symptoms, but that does provide evidence that the disease is progressing. And if that is happening while you're on a particular type of treatment, it raises the question of whether your treatment is fully holding your condition in check. Now, I don't mandate that people come in at any defined interval every 6 months or 12 months or 3 months or anything like that, but my point is that just because you perceive your MS as stable, that may or may not be the case. There can be evidence of progression that you aren't aware of, and seeing your neurologist at regular intervals and having a surveillance MRI scan done every once in a while is one very good way to screen for that. So you have to be a little bit careful in that regard. We love to see people who are doing well, and we love to tell people that their MRIs are unchanged or improved, but the only way we're going to be able to do that is if we get you into the clinic and meet with you face to face. I don't know, someone, Dr. Maldreer or Dr. Siegel maybe can chime in on this. So somebody asks, interferon beta has recently been shown to have no effect on disability. So why should anyone take it? How does Copaxone compare in terms of long-term disability?
Well,
Speak into the mic, please.
I could elaborate on that. As I showed you the graph, all the disease-modifying treatment, when you start earlier, when people still have inflammation, active relapse, it helped to prevent long-term disability. It may take 10 and 20 years to see the progression. But the drug have been shown to be effective only when you use them early on. So definitely there is benefits in the long run, even though you don't immediately see it. So early on means when you were initially presenting a set of symptoms, and how many years? Just when you first start to have trouble with vision or numbness and tingling, weakness, when you initially diagnosed. We have found any time when we start disease-modifying treatment earlier, the benefit will be for preventing progression in the long run. But
what if diagnosis is significantly delayed from the actual start, like 14 years?
Oh, I see. So you may be one of the lucky ones. What we could even call it benign MS, because we're delayed in diagnosing. In that scenario, there's still benefits because you would continue to have relapse. So by starting the disease-modifying agent earlier, you can decrease the relapse rate and decrease further MRI lesions and further damage to neurons. I don't know if that answers your question. David can.
So maybe, Ben, there was this recent report to suggest that patients who had been taking beta interferon for long term were not necessarily delayed in the development of disability. That generates some confusion out there because we're talking about early treatment and delaying disability. So can you speak to that study and help clarify for the audience?
So there's some conflicting data out there. There are studies that show decreasing relapse rates when you're in the relapsing remitting phase could delay the onset of the secondary progressive phase. And we know patients who have more attacks early on enter the progressive phase sooner on average than patients who have infrequent attacks, and these drugs do decrease relapse rates. I think the writer was referring to a recent Canadian study. It was an epidemiological study in which they followed patients who were on beta interferon or who were off treatment for a particular period of time. So, as you know, medicine is nationalized in Canada, so they have a registry where they track virtually all the patients with MS, and they could go back and look to see if patients were on drug or not on drug, and then after a certain period of time, whether they got worse in terms of various measures of neurologic deficit or dysfunction using scales that doctors Braley and Maldreyer mentioned earlier. So in that study, they found that the patients who were on beta interferon for, I believe, on average a 5-year period compared to the patients who were not, there was no difference in how much deficit they accumulated or how much more they became disabled over the time interval. But that's one study, and there's some caveats to it. Number one, the patients who chose not to go on treatment tended to have less severe disease, so they had less relapses. So you could argue, well, of course they didn't progress as more because they had a milder disease in the first place. Now, the statisticians who analyzed the study said they accounted for that, but you can't account for it fully. So I think what it comes down to is that there's some conflicting data. The majority of information suggests that treating patients with relapsing remitting disease with these drugs to decrease relapse rates very likely delays the onset of the progressive phase. But we do know that when you initiate drugs during the progressive phase, most of the data indicates that at that point they're no longer effective. So it's a mixed picture.
So maybe I'll ask Dr. Braley to comment on this. So the question has to do with management of pain in patients that have MS. And can you comment on strategies or treatments available for pain control? They mentioned several medications, but the questioner also asked about the role of spinal cord stimulators.
Yeah, so it's a complicated question. You know, there are different types of pain in multiple sclerosis. Some of them are related to the MS itself. We call that neuropathic pain, where actually the pathways that control sensation are malfunctioning because of the MS, and your body perceives that as a feeling of injury, a feeling of burning, or needles and pins, or sort of a shock-like sensation. And oftentimes those types of pains are very well managed with medications that we use to treat other conditions. So anti-seizure medications, for example, can help calm those nerves down. There's also some medications in the antidepressant category which can help with that. And you think, gosh, why would I take an antidepressant for pain? Well, it actually, because a lot of the chemicals in the brain that these drugs work on overlap, and they actually do have some benefit. Now, if you're talking about muscle pains and muscle spasms, sometimes what we call muscle relaxers or antispasmodics can be helpful. But there are so many different types of pain, it's sometimes it's difficult to drill down. If it's joint pain, if it's bone pain, if it's related to an orthopedic issue, even that maybe the MS caused the orthopedic issue, but it's an orthopedic issue, then sometimes anti-inflammatory medications can be used. But if it gets into pain that doesn't seem like it's stemming from the MS, we do often employ help from pain specialists and sometimes even rehab specialists to help manage it. Spinal cord stimulators, that is typically managed by the pain specialists, and sometimes with the help of the rehab specialists. You have to have specific types of pain, and you have to have special testing done to see if you would be eligible for it. I'm not sure I'm the right person to be commenting on the details of what would make people a good candidate for spinal cord stimulation, but if anyone else wants to add anything.
So another questioner asks about cognitive changes in patients that have MS. And the question is, are there therapies to help with short-term memory loss? So I'll start the conversation there, and anyone can jump in as you need. So as I'm sure everyone is aware, there are many neurological diseases that cause memory impairment. And those have been really quite difficult so far to understand and treat. There are a couple of medications that are used for patients with Alzheimer's disease that have been able to slow the progression of cognitive decline that occurs in that disease. And there is limited experience using those medications in patients with MS. There is lots of off-label use of these drugs. There isn't convincing evidence that those medications slow cognitive decline in patients with multiple sclerosis. The other thing I would point out is the injectable disease-modifying therapies, the interferons of the world, for example, have been able to slow the decline of cognitive change in patients compared to people taking a placebo. So in some of the original studies where these drugs were being tested, they did cognitive testing in both groups of patients, people on the drug and people taking a placebo. And it was very clear that there were a subset of patients in both groups that had some cognitive impairment on formalized testing, and that the change or decline in cognitive function was slowed in patients taking beta interferon. So one way to attack the cognitive symptoms is to aggressively treat the disease itself. And so the disease-modifying therapies do have some effect on cognition. Anybody want to comment on that?
I'd like to just add that that's also been shown with Tysabri and adalimumab. And actually, if you ask any MS doctor who treats a number of patients with Tysabri, a significant percent report that they feel that they're mentally sharper on the drug. That's not completely understood, the mechanism underlying that, but there is also some real data indicating that there may be some benefits in terms of preventing cognitive decline in patients on Tysabri. The other point I wanted to make was that there are things other than MS that cause cognitive changes. So if someone comes to me with complaints of memory loss or difficulty concentrating, we also look for other conditions that could be responsible and that could be treated or reversed. For example, vitamin B12 deficiency, abnormal thyroid function, some blood chemistry issues. Sleep apnea also causes problems with memories. So all of these comorbidities or conditions that could occur in combination with MS should be investigated.
So I just want to echo the voice, because a lot of time you talk about memory difficulties. It's a very non-specific complaint. You really wanted to explore comorbidities, perhaps mood issues, depression, and lack of sleep, and sleep apnea. Those are confounding factors that we could actually treat and make you a lot sharper, not necessarily MS related. So we want to cover all that basis. Thank you.
Okay, I'm going to direct the last question to Dr. Braley. She gets the last word here. So once BG12 comes out, can it be taken as a replacement for Copaxone?
So that would be the goal. If the FDA does approve this medication, the goal would be to use it as monotherapy, meaning the therapy for your MS. You shouldn't need to be mixing medications, and often in MS we don't mixed medication. So this would, if this works out and the results look as good as we think they look, this would be in lieu of the medication that you're currently taking. But you always have to remember, again, it's great that we have these promising experimental therapies, but always make sure that you're talking through the reasons with your doctor about why you want to switch. Like, say you're on Copaxone right now, and the Copaxone is controlling your disease well. If your MRIs, from visit to visit are stable, if your exam is stable, you always have to think about that switching to another therapy might cause other issues. So just keep that in mind, But yes, this would be a replacement for Copaxone.
Okay, on that note, I know it's been 3 hours here in the auditorium. We want to thank all of you for coming again and sticking with us and paying attention, and for the fantastic questions that you've all asked. We'll keep the note cards. I'm sorry we couldn't get to all of your questions. I hope some of us can stay around for a few minutes at least afterwards. But once again, thanks very much, and I hope it was worthwhile.